I love to speak with my patients. I must say, to me, that is therapeutic. So, for me, that is just one of my limitations working with the COVID patients, because I love to stay at the bedside and actually speak with them.
It has been challenging because you're new to the profession, so you're trying to learn about your profession while working in a pandemic, which has been a challenge because ICU is not an area that you rotated through as a medical student per se, or even as an intern. So learning how ICU works was challenging, but with the guidance that I have in terms of our consultants and our senior residents, we're guided closely and quite well. So we learn the ropes and we do our best as junior staff in the pandemic. When you're assigned to COVID, the first thing is the handover. So the off-coming team gives you an overview of what happened on the shift, and you take the handover, and then you go in and you see the patients. So you assess the patients after having received the handover. You make any changes to the current management, if needs be, and you come out after that and you go in as necessary. So you're going to do another assessment of the patient. If anything happens, if there's any deterioration of the patient, you go in again. So, and you coordinate with the nurses, so you work together with them a lot. So I would say for most of the day, someone is always in the unit with the patient.
One Sunday morning, they called and said, "Sister, there's no one here, no senior person here to take over the unit, whole ICU." So, with all that I had to do, I'm a nurse first, so I had to just put it aside and come and take over. And the nurses were good because they concentrated on the patient while I concentrate on the management and see that they have the requisite things. And there was another instance. They had a mother first in COVID, in ICU. And we thought the poor mother would have pulled through. We lost her. And then the daughter who she got it from came. But she managed to pull through.
What was that experience like?
Well, with my experience over the years, you know that I felt it for that daughter, knowing that she was the one who was responsible for having transmitted it to the mother. But then you, as the person at the helm, you have to hold the boat together, even though you are feel a way to know that, that poor lady was at home, as it said, minding her business. And well, the daughter came and visited and she back. You learn to empathize with the family. But it was joyous when the daughter went to the ward and they had big celebration on the ward.
I love to speak with my patients. I must say, to me, that is therapeutic. So, for me, that is just one of my limitations working with the COVID patients, because I love to stay at the bedside and actually speak with them. But in this case, I can't be there as long as I want to. But some of the things that they highlight is the asking about their family members. They always want to know, can't their family member come on the inside, And you have to, just reinforce that they're in isolation and, they can't come in.
Communicating with the families, that to me is the most difficult because we can't communicate in person for multiple reasons. One reason would be the patient's relatives themselves that may be in quarantine because they also have COVID. So we have to communicate over the phone. And also when the patients are not doing well, and we have to give bad news on the phone, which we prefer to do in person, had it been another situation or in ICU. So that to me is the most challenging. And another aspect would be the post-COVID. So I think the public may think that post-COVID you're good to go, but that's not the case, especially for ICU patients, because sometimes COVID has damaged their lungs so much that they still struggle after COVID. So they go to our other unit, and some have passed in the post-COVID period. So I think they think that when they're out of COVID ICU, that's it, but that's not always.
Compliance was very good, pretty good. Hand washing, I must say, is also one of the integral part of infection control. And before COVID-19, our compliance rate with hand washing was not what you expected.
Among staff?
Among staff members, right. So since COVID-19, and everybody's aware that the hands are the culprit of spreading infections, then you have a higher compliance in hand washing. So yes, that's an improvement for us in terms of infection control.
We are 25 nurses short.
How many nurses in all do you have?
No, this cadre was before we added more to the ICU. So because originally we did 8-hour shifts, but because of shortage, we now do 12-hour shifts. So we would have had 3 shifts. The morning shift, 7 to 3, overlap of from 2:30 to 10:30, and we usually have from the 10 o'clock till 7:30 next morning. So we just have 2 shifts now, 12-hour shifts, just to maximize what we have. So we should have had for 8 beds, 60 nurses. So if we had 60 beds, we should have had 120. And that is not inclusive of the supervisory staff. Because we have had 2 shifts now, and this was just worked out for 1 unit, 70 nurses, 8 bed. So we need to rework for the added beds. So when we said 25 nurses short, 25 nurses short on the 70.
But you've been able to pull it together.
What has been happening? You have nurses who, when they're on their day off, they'll come in and do overtime, what you call sessions. And that adds to the fatigue. They see their colleagues overworked, so they're coming in to assist.
One of my most challenging times was when there was a surge. I think that was in August, when the unit was full. We were at our capacity, and the staff, the amount of staff was the same as when the count was low. Hence, the staff had to be in the actual unit for an extended period. So usually, when you go in, depending on the amount of patients that are in there, you would spend maybe up to 2 hours at maximum. However, at that time when you had more patients, we had to be spending up to 4 hours in the unit, wearing the PPEs and abiding by the actual guidelines.
And what did that mean? How did it affect or impact, rather, staff?
Well, that impacted the staff. There was burnout at that time. There was excessive use of the supplies or PPEs, or more use of the PPEs. There was persons who actually called in. The staff was actually stretched at that point, because in the initial phase, the staff would be on the COVID rotation for about 4 weeks, but at that time, it was stretched to 6 to 8 weeks per rotation.
And the rotation is that you work 4 weeks in COVID and then 4 weeks in non-COVID?
No, you would work 4 to 6 weeks in the COVID area. You get like 3 days break, and then you go to the regular wards.
You go to the regular. Were you fearful at the start?
I would think everybody was fearful. There was fear of the unknown, because this was a new virus, so to speak, and how when it came about, it's like it wasn't sure the source or how it was spread, because initially I think they said it was contact, and then they said it was actually virus and it was droplets. So there was a scare.
So you were nervous at the
initially.
start?
But then once I, found out it was actually a virus, I treated it like any other virus. Hand washing, which I always do after touching patients, coming in contact with patients. So that was utmost, that was continued. The PPEs, however, usually we would wear PPEs mainly when we have a patient who needs barrier nursing. And that would be like one nurse would be assigned to that patient throughout the day. The patient would be barriered and so forth. So it's only at that point you would wear PPE. But now, once you're in the COVID era, you would have to, once you're coming in contact with the patients, you have to ensure you are fully done before going in.
According to WHO recommendation, elimination is at the top of the hierarchy when it comes to infection control and in the context of COVID-19. And in eliminating, environmental cleaning is one aspect. Environmental cleaning is effective in reducing the viral load of the virus and even getting rid of the virus within the environment. The COVID-19 can live on surfaces for a very long time. And when that surface is not cleaned properly and other persons go and touch the surface, they can transmit the virus to themselves in that manner and to other patients as well. So environmental cleaning is key when you want to eliminate the virus.